A 63-year-old woman presents with progressive muscle weakness in both legs, leaving her unable to stand or walk for a week. Her muscle strength is rated at 4-5, and she has slightly diminished knee reflexes, but normal pain, temperature, and vibration sensations. She has no recent history of infections, which could have suggested a post-infectious etiology. The neurologist initially considers Guillain-Barré syndrome, GBS, an autoimmune disorder that causes rapid-onset muscle weakness. However, the usual progression to include upper limbs and respiratory muscles does not align with this patient's presentation, leading the neurologist to rethink this diagnosis. The neurologist then contemplates transverse myelitis, an inflammation of one or both sides of the spinal cord. However, the absence of upper motor neuron signs, increased reflexes, positive Babinski sign, does not support this diagnosis. An MRI of the brain and spinal cord is ordered to check for signs of spinal cord compression, transverse myelitis, spinal abscess, or any brain pathology. The MRI results are normal, ruling out these conditions. A lumbar puncture, LP, is conducted to analyze cerebrospinal fluid, CSF, which can aid in diagnosing conditions like transverse myelitis, GBS, and infections of the brain and spinal cord. The LP results are normal. With normal imaging and LP results and the patient still unable to move, the neurologist considers a psychosomatic disorder, especially after learning about the patient's severe depression following her son's suicide a year ago. This diagnosis is given more weight after reports that the patient can stand when unobserved. A psychiatrist is consulted and confirms major depressive disorder, further supporting a psychosomatic diagnosis. Despite this, the patient's condition deteriorates, leading to complete immobility of the legs. During emergency medical intervention, a spinal artery thrombosis is revealed through a repeat MRI, diagnosing the patient with spinal cord ischemia, also known as anterior spinal artery syndrome. This condition was initially missed, highlighting the importance of considering vascular causes in cases of acute paralysis, especially when initial tests are normal but clinical symptoms persist. This case underscores the importance of a thorough diagnostic process, which includes keeping an open mind to all possibilities, careful reevaluation, and the need to exhaust physical causes before considering psychosomatic diagnoses. It brings to light the challenges in distinguishing between neurological and psychological symptoms.